So let's talk a little bit now. Let's shift things. So we talked about the procedure. Let's step back before the procedure, and I'm curious at each of your respective institutions how you bring together the workup of the patients, the decision making, the multidisciplinary approach. For example, Ignacio, at MGH, is there a multidisciplinary clinic? Do you have a process by which the different disciplines come together to come up with a conclusion for the patient?
It's a key element because obviously it's a multidisciplinary evaluation. You know, we need input from neurologists, cardiologists, many times hematologists if you have a hypercoagulable condition, or vascular experts if you have a May-Thurner anatomy or nutcracker syndromes and so forth. So the input to our program comes basically from two fronts. It's either neurology or cardiology. I have to say, since the approval of the device, we've seen a lot more referrals from neurology into cardiology and not the other way around, which used to be the case before the approval. We don't quite have what is my dream, and I'm working on this, is to have one clinic in which the patient will be seen by both specialists at the same time, and neurologists and cardiologists. Logistically, it's hard in our institution, but I make the effort that patients should see the neurologist first, because I think a lot of obviously the decision making of whether someone warrants a procedure or not is based on whether it's truly a cryptogenic stroke and not something else. But sometimes the patients come to see us first, and we, in every single case, get a neurology appointment with a stroke neurologist that is sensitive and knowledgeable about what PFO and cryptogenic strokes are. The number of neurologists that appreciate that is growing since the clinical trial, but I think everyone still has some challenges on that.
So there are stroke mimics in young patients, multiple sclerosis and the like, which we need to exclude, right? Because that can have even ischemic changes on the MRI. The second, as you make a good point, is that not all neurologists are privy or are up to date regarding the multiple randomized clinical trials that support the therapeutic benefit of closing a PFO in the setting of a cryptogenic stroke, which should now, I suppose, be called a PFO-related stroke rather than a cryptogenic stroke. John, at SNU, what's going on in terms of workup?
Our institution, again, having had it up and running for such a long time, we get referrals a lot from the outside. And in that situation, though, I am not a neurologist. I'm not that smart, and I have to turn it over to the neurologists out there who've evaluated them and said, listen, we think that their ROPE score is fairly high, as I often call it, the anti-CHADS VAS score. So even with a good ROPE score, it's still only 80-90% probability it's related to the PFO. So we do an exhaustive study to make sure that everything else has been ruled out. Now more and more people having 30-day event recorders, because we found out from prior studies that closing a PFO that about 10 or 15% of people did have AFib that we didn't pick up just with.
Well, we'll talk a bit about that. I mean, let's talk about monitoring. You might have to just talk about monitoring.
Sure.
Because I think it's not controversial, but there's not that much data regarding it. We know in the Crystal AF study, so that were link devices in patients with cryptogenic stroke who were generally, I think it was over the age of 55 or 60, I believe. And you saw that if you were less than 65, at 4 years, the rate of AF was still quite low. It's like 4%. So you get 30-day monitors. Some places do 2 weeks. What's your threshold for putting in, say, a link device or one of the other devices that allow long-term monitoring? And if you put in one of those devices, how long do you wait until you give the all clear? Ignacio.
Yeah, it's interesting. You know, I'm the principal investigator for the Gore post-marketing approval study, and this question has come to in the terms of developing the protocol. We initially have said 2 weeks of recording was enough for most patients. The FDA actually came back and said that's not enough. Probably, I'm going to guess from a lot of input from neurologists, because there is the neurology community. The Crystal AF has gotten really deep into neurology and not necessarily that deep into the cardiology field. So basically, what I think should be done, and this is what the protocol says, is under the age of 40, you need a month of mobile cardiac telemetry is what we use, or 2 weeks of patch recording, which sometimes is difficult to get. I think between the age of 40 and 60, if you have risk factors for atrial fibrillation, namely hypertension or a large left atrium, or some congestive heart failure, then you have to think about whether this patient should have a more prolonged period of monitoring before the procedure is done. I personally, if I have those risk factors, I would elect to put an implantable loop recorder on the patient and do at least 2 months of AFib recording. And certainly above the age of 60, I'm routinely using the implantable recorder.
Yeah, so in Crystal AF, if you're a younger patient that had normal PR interval, the chance of detecting AF was very low.
Right.
So just the 12 lead EKG, if they have a prolonged PR interval, there might be a trigger for longer term.
Right.
I interrupted you, John.
No, I think I was just going to expand on that spectrum. I mean, the lower probability of having AFib requires a less rigorous rule out. Right? So, Holter monitor 24 or 48 hours is probably adequate for that person. But the higher you get up in age and in risk factors, the more likely you are to have to go out to extended time periods.
Right.
And in fact, I think one other message you want to bring across, because you mentioned insurance issues. There are some insurance companies not allowing this to be done in people over the age of 64, 65.
Right.
However,
60,
it doesn't mean, or 60,
Yeah.
it doesn't mean that those people haven't had a paradoxical embolization.
It is
So
the
if
magic
you can
thing
find
when you turn
nothing,
61, yes.
And you do a prolonged recording, I still think it's valid to go ahead and close those folks.
And remember, the FDA indications for these devices are patients who are generally less than 60 years of age, not only. The other thing I'll just throw out there for a little controversy is, let's say you have a 42-year-old female with a massive, with a stroke, say an MCA stroke, aspiration, she recovers. You do the bubble study, large aneurysmal septal aneurysm, big PFO, constant shunt. And you do a long-term monitor, and there's 2 minutes of AFib during those 2 months. Does that mean that you should anticoagulate that patient for AFib?
It's low burden. Low AFib burden.
What is, so it's you could argue for a belt and suspenders approach.
Yeah.
So again, it's not that easy. Just if there is some atrial arrhythmias, the patient should not get a PFO closure. It's not that easy.
I agree. It gets more complicated, but doing due diligence, particularly on these higher risk patients, still may qualify them for PFO.